So maybe it's not small, medium, and large. It's vinyl, terrazzo, and marble. So we'll touch all of them. See a lot of friendly faces. We're not here to lecture. We're here to share. So two-way street. Please interrupt anytime. I'm good with that. Now I need to find a clicker. And I did spend about 20 years in Texas before I got kicked out of the country, and they asked me to start office in Singapore. So I do my laundry in Texas and in Singapore, but I do travel around. So we do see a lot of different ways of doing things. So today, I like to go through using the different scales of project from different locations around the world, just to do a quick round and see the differences and the similarity. That really is what we want to get to. And how do we scale up and scale down? Some we cannot scale up, and some are really designed for scaling up twice as big if we want to. Okay. At any point, HKS, why am I here? At any day, like right now, today, we are delivering and designing over 500 hospitals around the world, big and small. So we do have the database, but I also don't know all of them. So if there's any question I couldn't answer today, I will be able to look it up later and follow up for any particular project. We know it's under strain. We know everywhere we go is faster, better, cheaper. You have heard it, and we've been hearing it for 20 years, but much more so now. Especially our, okay, I'm not going to talk about our president, but there are things happening around the world that makes things even more expensive right now. Evidence-based design is not new. Actually, we call it evidence-informed design now. It's not really evidence-based. But now, as architects and planners, we know better how to apply them. Before, we just kind of know about them and know they exist, know where to find them, but slowly we know how to apply them. A lot of them, by the time you know it, is quite basic. Okay, there's nothing too revolutionized about it, but we can use it to talk to users about it. It's actually very helpful, and it's the most helpful when we can't close a user group meeting and I pull out all the evidence and that's it. This I can tell them 300 hospitals are doing this. We have proof that this is the way. So it was very helpful for us to sell and to close. And then no matter how rich or poor a country I go, doesn't matter, and I'll show you, everybody has a budget. Okay, and we need to respect that. Okay, so the 5 pillar. Again, I hope it shouldn't be new. Of course, we want to design to operational efficiency, flexibility, adaptability, technology integration. So there are a lot of things we don't know now. We know AI is going to disrupt how diagnostic will work. You start with eye clinic. You can diagnose with AI now when we talk to the users, but how does it change the environment? We don't know yet. We're actually in the middle of that conversation. Healing environment, sustainability, I'm going to skip those today, right? Preaching to the choir. So the first hospital that actually it's a clinic that we'll go through is about 7,000 square meters. I'm looking at my notes here. The medium one is, the small one is in the Middle East. It's for a prince. Marble. The middle one is in the U.S., so some terrazzo in the public area. It's very common, very, very common. Durability, all of that. And then the large one is a public hospital in Singapore that we finished detailed design, now it's under construction. So I can show some pictures, but please be gentle. Some of the photos we might not be able to share without the client's consent. Okay, so we'll go through that. Small. Do I have to say anything? Just because you have money doesn't mean we should spend it for you without any thought and be careful about it, right? So even for a small clinic like that, all the exam room, I'll show you my picture. Exam rooms, You see the public space, we really do try to make it as repetitive and as regular as possible. We are not here to say just because you have money, we will help spend it, but we did spend a little bit. It's symmetrical because it's the Middle East also. You cannot be too, well, for clinic and for this particular client, they like symmetry. So it actually helps us to make things repetitive. Okay. So we do have a small footprint. Like I said, there's still limitation no matter how much money you have. Modular, we try to make everything marble but modular. Daylighting is everywhere, right? So I'm going to pause a little bit here. This is our exam room. The doctors in this part of the world, the doctors don't move around to see patient. I stay, you come to me. Okay? So we have to make this comfortable for the doctors, have to have a place to wash this, turn around and wash the hands and all of that. It's very common. And also privacy is important. So we didn't show the curtain track, but even within the room, if it's just a patient and a doctors, you still need some modesty, some privacy for them. So that's the screens, that's what the screens are for. A room is a room. We still need to have all the med gases and equipment that we need. We just try to make it as luxurious as possible because it was a requirement. But like I said, exam room, we don't have bespoke. It's really, no matter how expensive the finishes are, it's still modular. Okay. The public space, we don't go crazy. You know, you do one art, it's the same. We have it march down the corridor. To us, it's really a sense of responsibility too. You know, how to handle our clients' money and speed. This definitely will be faster if everything is repetitive. So this is really the theme that will go through that we will go through the next 30 minutes, 25 minutes. Okay, so it's ingrained in us. I've been trained for 30 years. Flexibility, even when I started in Little Rock, Arkansas. Well, the first project was in Little Rock, Arkansas. We were already talking about this. How do we create a spine? How do we add patient part along that spine? I'm brainwashed. I don't know how else to do it differently. Okay, must be flexible. I've been told hospital is a living building. It changes every year. Let it grow. Okay, Children's Hospital at Richmond, Virginia, Commonwealth University, patient tower. So this is just a patient tower expansion in the US, a medium size. Okay, you can start seeing tile instead of marble. I know it's not funny, but you can tell the finishes is different. Okay. And the exterior, so very straightforward, right? So we always go through, is it decentralized or centralized? Really, up to today, 30 years later, we still have that conversation. It's still 50-50, okay? Outboard toilet, inboard toilet, still 50-50. There's no winner for 3 decades. Prefab components, okay, you can read this, but I want to show you. Color is a children's hospital. Sometimes we are too liberal with color, but this is what the clients ask for. But I want to show you the plant, okay? Very straightforward. 2 nurses stationed on each corner, almost a mirror image, because in the US we do want to minimize nurses' walking distances. Actually, everywhere we should, but that's always the first thing they ask because we have nurses there in the 60s, and we really, every step count. We did actually a study of nurses' walking distance, and by changing one thing, we reduced the walking distance by 1/3 because of where they place the applesauce. It's famous. They walk back and forth, try to get applesauces for the patient. All we have to do is move the fridge closer to the nurse station, and they cut their walking distance. We don't think about it, but you kind of have to, like, why are you walking so much? And we shadow them and find out. It's not architectural. Nothing to do with architecture, but we got to understand how they work. So, floor plans, and we do a sightline study. Nothing new, but see how regular it is, how symmetrical it is. Also, we would go through experience mapping. Good experience, bad experience, the range, and why. So when we start this project, we went through design thinking, so it's also very normal. And then for this particular project, we do have do study afterwards, per-occupancy evaluation, sorry, and we understand some of the improvements that was brought to the project later on. Okay. This one is near and dear to my heart. I almost look at it like a video game. How do you scale up, scale down? Keep the circulation clean. Don't cross the workflow. What happened when there's a pandemic? What happened when there's a civil emergency? It's different. Pandemic, they come 1, 10, 100, maybe 1,000. Civil emergency, they can come all at once with 200 people in the ED. So it's not the same. Scalability also, if we have to expand certain department and scale back, also is a totally different game. For horizontal building, it's different than high-rise. Okay? I throw in another high-rise story for you later. Okay. Very straightforward. Why? Because we have to save money. Okay? Now, this is the one that I actually worked on at the very beginning. You can already see no thrill. It's a government hospital with 1,500 beds. It's very common. The largest that we have done is, I think, 2,500 beds, but this is it's nothing unusual for the Singapore government. They have an army of people to look at operation, clinical outcome, look at the catchment area. We try to provide advisory service with 2-3 people. They're like, no, this is, we have hundreds of them. Okay, so we will receive, we receive a brief that you must stick with, just like Australia. You got a brief and you stick with it, right? So I'll tell you a high-rise story. Do I have time? Okay, we have time. I'll tell you a high-rise story because I know some of you mostly, are eyeing maybe a future project that's high-rise somewhere in one state in Australia. So currently we're working on a hospital that has 5-story of podium, not this one, 5-story of podium. One that's patient tower to add up to about 28-story. Another one is about 20-story, is all administration, right? So we thought, no, we didn't think. The client think, maybe, what if my CEO want to go across to see to the patient unit, to visit the clinicians, visit the staff, right? Have a bridge to cross over. Makes sense, right? Because you don't have to go down to 7th floor, go across and go up. The implication is when you do something like that, we really mess up the elevator lift core, right? The minute you have a public connection or even staff connection, they go across, the number of lifts will increase. And it's very hard to calculate how many lifts you need. Wait time will increase. Our baseline for wait time is only 20 seconds. Cannot be more than 20 seconds. If it's 30 seconds, we have to add another lift. So the moral of the story is sometimes it might, for high-rise building, sometimes it might make sense to say, hey, just walking distance, our CEO don't want to walk so far, but the implications is huge. One lift, 28-story, you know how many OT you wiped out? A lot. Okay. So for a large building, tall building, those are the nuances we have to look out for. And that just happened like 2 days ago. That's why I want to share. Okay, this little guy here, we have to, the order is, we didn't do the exterior, but the team that were doing the exterior design was told, it's public money, it's taxpayer money. Even though the government has money, you cannot make it look expensive. They just say, look, it can be very expensive, but you cannot because the taxpayer will complain. So there, there it is. It is taxpayer money. Who's going to answer to it? Nobody wants to answer to that. Now, so with this particular one, because it's big, we want to zone it by acuity, from high acuity to low acuity. So when you look at the ED, it's really from high acuity to low acuity to high acuity, and then you go on up to OT, ICU, and recovery. So you can literally draw a continuous line where the patient will go from the minute they come in to rehab. We do have template on room design for standardization now, but when we designed this one, there isn't. Flexibility, I'll talk a little bit about it, and then vertical, horizontal circulation is as clean as we could make it. It is planned for pandemic, planned for civil emergency. All work, we test it. Okay, so I just want to tell you that, so share that when I was younger, when I started, flexibility is, like I said, don't block a corridor. You have a staff, private and public, don't block it so you can expand. Now we learn there are layers and layers of different kind of flexibility. Okay, and we study in such a point that we can actually measure it. Before it's like, my hospital is flexible. Well, how flexible? I can actually tell you which room is convertible, which room you can just turn it into something else, and which room you can just change the name and have another function. We can measure it now. So we divided it into versatility, modularity, convertibility, and scalability. And each one of them also have a dollar sign. If there is anything I want you to remember, is something like this. Identify how they are flexible for your client, how they are flexible, why they are flexible, and each one of them has a dollar sign attached to it. Okay, some are very, very low if you just change the room name. So, okay, for flexibility at different scale also, when you have a large hospital, there's a campus. So it needs to be flexible between campus. The entire building needs to change to something else one day if we need to, okay? And of course, the floor has to be flexible. Maybe if there's a pandemic, only one floor is start with isolation room, but at the end, the entire building is isolation. So we plan for those. Within the floor, each room needs to be flexible, and within the room itself also needs to be flexible, right? So there are different layers now. How you convert it, and within the campus, from large scale to small scale. Some of the foundations, and this will help with high rises too, is we need to start looking at pushing the core out and have modular grid. For us, the challenge is always no transfer beam. If we have a transfer beam, it's considered a failure, okay, for this particular client. Not for us, not for all of us. But if you have a transfer beam, you fix it. It will not stop until everything just go up and down straight up. Can you have two-story space? Of course you can, but you just have columns in it, okay, for this client. Because it's money. They watch money. In Singapore is the closest to you, and it's also where we are working right now. So we designed user approved, hospital approved, Ministry of Holdings approved, Ministry of Health approved, Ministry of Finance has to approve. At the very end, MOF has to approve. And they have architects in MOF. They will challenge you. Okay? If they are not satisfied, you won't get the money. You resubmit. Redraw until I'm happy and you can get the money. Okay? We talk about this, how you scale up and down. I'm not going to go on and on about this, but there are different layers, right? Same with the floor plan. So, this one, the previous one was about the building. This is about the floor. Let me just pause a little bit because I can't read through all this. Okay, I got 10 minutes. And then, of course, the different typology. Okay. And we also have designed our own patient pod. We started it more than 10 years ago, taking cue from the business class flight and the surrounding, the setup. So we designed it. It took us an entire decade to get through the government and get approval, and now it's in the US guideline. You can actually, it is approved, and we can use it. How it started was, we know that when we go to an emergency department, about 50% of the patients are ambulatory. They don't need to lie flat, right? So why do we need to give them? I go to ED with a few stitches, I can sit up. So the 80 square feet compared to 120, 150 square feet is a big difference, almost 2 times. So we were able to save the client a lot of money because of the square footage, or they can see more patients, and the sight line is also better for the nurses. So I wouldn't call it innovation, but it's a huge improvement when we were able to get this, our design approved and get it into the country guidelines. Okay. We talk about space because we're architect, but flexibility is more than just spaces, right? We want to design the places where the nurse can be flexible with their hours when they come in, and better use of money. Pandemic resilience strategies is something that we have been looking at. We actually have a hospital built that has that strategy. It's already completed. We started that pre-COVID. Because we were aware of, before it was SARS. So it was SARS, so when we plan this hospital, we know there is going to be another pandemic. It will happen again. After this, there will be another one. So right now, we are planning everything that within the infrastructure of the hospital, it can be blocked out. For high-rise, certain elevators, instead of soiled elevators, it might become pandemic elevator. And for a certain period of time, one of your staff elevator or patient elevator could be your clean elevator. So we have to plan all of this and make sure there's no crossing. Okay, we test everything. Okay, let's see. You're looking at the resiliency in the campus level. So on a building level, we usually start with 1, and then the first one's always placed on top of ED and OT. Makes sense, it makes sense. And then the pandemic elevator, the lift, always open to the emergency OT, right? And the isolation OT. Both of them are the closest to that one particular lift. And then it can scale up. Scale up, meaning part of the OT will be isolated, and then the other part will be business as usual. But it's not always 50-50. It could be 20. It can scale up and down. That's what I'm trying to preach here today, is make sure you can scale up and down, not from 0 to 50 to 100, is however range you want it, because your circulation is planned for it. Okay. All right, sustainable strategy, that I'm gonna skip a little bit. The idea of the hospital is we lift the hospital up so that green can go through. But this works better when you have a humongous hospital. Okay. Okay. All right. So there are a few common threads. Some are just low-hanging fruits we know we have to do. So when we're designing a flexibility hospital for scale, don't lose patient-centered design. We don't lose that. Don't lose track of that. The other thing is efficient functional flow. That actually, to me, is the most difficult. Because you test and test and test, and then, doesn't work, start again. Many, many iterations to make sure we test all the workflow to make sure it works. Flexibility and future readiness, of course. Connecting to nature. So when you plan on expansion, a lot of time I've seen the only way to expand is to block all the windows. to expand the next building. So plan ahead, don't do that. Staff well-being and operation support. So latest research paper, we have almost 10 PhD in our company because we've got scale, so we can spread them through. What they're studying right now, the hot topic is in the U.S. is nurses burnout is a real thing. So they're doing some research and see how and what we can do for the nurses. That really is an effect that come out of pandemic, burnout. Okay, so what can we do? Some of the points there. Infection control and resilience, we already talked about it. Energy efficiency. The hospital, the 1,500 bed hospital in Singapore is going to be platinum, at least platinum gold, I think, for sustainability. So it's a tall order for hospital, not for hospice office building, but for high energy consumption building. It's difficult. Community integration, don't lose track of that. Okay, so I would like to share, that's the end of it, is it's not about, maybe it's a little bit Asian of me too, not about spending more, it's about value. It's about value, okay? No matter if it's marble, terrazzo, or vinyl, every dollar count. And that's why our client, I believe that's why our client really, really like us, is one of the things that we do is we protect them. We don't go and say, oh, I can give you the iconic building, you will win a lot of design award. I tell you 90% of them, they don't care. They actually will be turned off. I'm here to help patients. I'm here to take care of the family. I really don't care if it's iconic or not. Well, they do, but that's not the first order. So as medical planners and health architect, from one professional to the other, I hope we can spread that word. We are not in healthcare architecture to win a lot of design award, even though I know all of you are very successful in that. But what a client, all 500 of them today, that's not what they're looking for. They want us to help them faster, better, cheaper. And we have a few tricks that we can share with them. Okay? Is that okay? I've got 2 minutes. Okay. Thank you.